live, Poonam. Yeah, go ahead, sir.
Hello. Yeah. So hi everybody. Basically, what we were trying to do through COVID, we started doing a lot of web meetings, and then we realized doing virtual fellowship is quite a nice idea to connect to a lot of people. Shall I shut the light behind me for a moment?
Yeah, a bit.
Is that better?
Yeah, it's better.
Okay. Chalo, ठीक है. So the idea was to share with you the philosophy of treatment of pediatric practice. Cold orthopedics is something that is quite variable, but pediatric practice appeals everybody because one, all general orthopedic surgeons also do children's practice, and the idea was to train everybody to do the pediatric practice in a better way, and to share with everybody my philosophy of certain things that I do in a particular way, my own techniques, some kind of thought processes which might help you in your day-to-day practice, as well as have interaction throughout the week, throughout the month, over 2 months, so that it helps you in your practice. Every
It
time when
seems
I give
your
an,
audio is not clear, sir.
you are able to hear me or no?
We are able to hear you, but sometimes the audio goes off and comes back. It is, yeah.
You want me to try?
Yeah, better if you try the wired one.
Yeah, I'll try the wired.
You have to disconnect the Bluetooth first.
ಅಲ್ಲೇ ತಗ ಬರ್ತೀನಿ ನಾನು ಮೀಟಿಂಗ್ ಐತೆ ಅಲ್ಲಿ ಇದಾರು ತೊಗೊಂಬರ್ತೀರ ನೀವು
Hello.
Yes, sir.
Hello.
Yes, sir. Can you hear us?
Can you hear me, Ashok?
Yeah, I can hear you.
Hello. Can you hear me?
We can hear you, sir. Can you hear us?
Yes, I can hear you. Is this better?
Okay. Okay, go ahead, sir.
Is this better?
Yeah, it is better.
Okay. Okay. So I'll start with the supracondylar fracture. I think it's the commonest one to know. And I'll try to make it as simple as possible from my side. We'll have some discussion interaction on supracondylar fracture. All right. Can you see my screen?
Yeah, we can see, sir.
Yeah. So what we are going to do is that I'll talk about supracondylar fractures as it happens, and if anybody has any problems or questions, they can either stop me and ask me, or we can do the questions in the end, in whatever way. So Ashok, I think you moderate so that it runs smoothly, right?
Yes, sir.
Yeah. So what do I hope to highlight in this particular talk is that when you get a supracondylar fracture, first thing is, do we need reduction and why do we need reduction? That is absolutely a basic question. Why are we treating supracondylars when bone setters have been doing it for so long? And even now people prefer to go to bone setters, right? Rather than coming to orthopedic surgeons. So they must be doing something right, which is why people still go to them, right? In every small city and even in big towns like Mumbai or Pune or Hyderabad. Second is we need to understand types as they exist. Third,
So I think the sound is still not clear. People are saying they can't hear properly. Even at my end, most of the time it is clear, but it then waves off.
what do you want me to do?
Can you
What
check
can
your audio settings?
audio setting? Where are they?
And the microphone?
Sir, try to switch off the video, sir, so that then maybe there is issue with the internet.
Is there an internet issue?
No, there is no. I am connected to 5G, full strength connection.
No, your audio is really cracking. Okay, like he said, if you can stop the
Okay.
video for some
Okay.
time and see.
I'm disconnecting everything. Let me use. Can you hear me, Ashok?
Yes.
Hello.
Yes, sir.
Hello.
Yes, sir.
Hello.
Video is not clear, sir.
Hello.
Yes, sir.
Hello.
Yeah, hello, sir. Can you hear us? No, I think
Hello.
he can't hear us. Let me call him.
हाँ अभी आ रहा है आवाज आ रहा है
Sir. Yes, sir.
This is better.
This is better.
Yeah, it's good.
हाँ डायरेक्ट कर सकते हैं without any jack or
Yeah. Yeah.
Hello.
Yes, sir. We can hear you. Can you hear us
Hello.
here? Can you hear us here?
हाँ you give me access for screen share. No, I can't see anything.
You can access, sir. Just click on the green button and share.
I can't hear you, Ashok.
Just click on the green button and share.
I cannot hear you.
Okay.
हेलो अरे बट मेरे इधर कुछ सेटिंग्स ही नहीं आ रहा है तो कुछ दिखाई नहीं हाँ बट वो अभी मैंने ओपन किया same as system. I cannot hear anybody.
Can you hear us, sir?
No,
Can you hear us on the
I
laptop?
can hear you on the phone.
Okay.
हाँ अभी आवाज आ रही है स्पीकर का माइक्रोफोन अभी सुनाई दे रहा है
We can hear you properly, but
Now I can hear you. Now I can hear you.
okay, okay.
हाँ
So-
अभी सुनो
Okay, then you can hear us, then let's start.
Yeah. अभी ठीक है?
Yeah, your voice is clear now, not cracking.
Yeah, okay. So somehow that Zoom thing has become so big that नीचे का जो बार है ना उसमें वो सब
No,
आगे
we
बढ़ा।
can't. We can still. Your voice is still cracking again. Can you say something, sir?
Hello, can you hear me?
Yeah, you can hear you. Once you come a bit closer and speak, then it's very clear.
Okay, I'll come closer and speak.
Okay.
Can you see the screen?
Yeah, you can share the screen.
Can you share?
Yeah, we can see. Yeah, now you can open the PowerPoint. So it looks like your PowerPoint is already full screen. So
Hmm.
yeah,
Hmm.
go to that. This one, okay.
Can you see?
Have you made it full screen?
Yeah. Can you see?
No, we cannot see because wait, I'll stop the screen share.
Hmm.
Go to share screen again and find the PowerPoint. Don't share the screen directly. Find the PowerPoint.
Yeah.
Yeah.
Can you see?
Yeah, now we can see. Go to full screen now.
I'm not able to see that.
Okay. So what you do is first you minimize your PowerPoint. I mean, don't go into full screen. I think you're again sharing the whole screen. Share only the PowerPoint. I'll stop the sharing again. Yeah. So click on share screen. On the options, you will see the PowerPoint also, which is open.
No, Ashok, you're not getting my point. In my screen, I'm not able to see the lower buttons which allow me to make it full screen.
What can you see now?
Nothing, all the icons below.
No, can you see the Zoom screen? Can you see me?
No, I can't.
Just open the Zoom then. You're not
No,
open the Zoom.
I opened Zoom now.
Now you can see the share screen green down.
It's getting partially hidden by my last line.
Okay. Still, can you click on it?
Yeah.
Okay. Once it opens, find the PowerPoint. Don't share the screen completely.
Yeah, I found the PowerPoint.
Yeah. No, it's the same thing.
Can you see my screen now?
You can see, but not the full screen version.
Yeah, but I can't. I'm not able to make it full screen.
So go to here on the top.
So go
you
to
see the-
slideshow.
Go to the slideshow and change that.
On top, sir.
Yeah, but
Slideshow. From
Okay,
beginning,
you can
sir.
start from the beginning.
Left side from beginning.
Okay, can you see?
Yes,
Yeah, we can
yes,
see
sir.
now.
Okay. You can. Can you hear me?
Yeah, we can hear you once you come closer a bit,
Okay.
which is much better.
This is okay.
Yeah, this is okay. Sir.
Okay. Now tell me, how do I get rid of this bar on the top which is blocking my view?
Are you moving the slides, sir?
No, I'm not moving the slides. I want to hide that panel which is coming in my way.
Just drag it somewhere.
Yeah, I've dragged it. Can you see me now? Can you hear me?
Yeah, we can hear you.
Okay.
But voice is still looking to be a problem. We'll see how it goes.
Okay, can you see the slide?
No, not clear. So audio is not clear.
Ashok, I can't do anything now.
So what you do is on your phone, can you join on Zoom and disconnect this? Keep the slide here Just disconnect the audio on
I'm
your
going to
laptop.
use my headphones.
Yeah, just try.
Hello.
Yeah. Hello.
Hello.
Sir,
Yeah.
any other tabs open on your laptop, you can close all the other tabs if any browser is open.
Can you hear us, sir? Can you hear us? No, I can't hear. It keeps on changing the audio setting. Can you hear us, sir?
Hello. Can you hear me?
Yeah.
You are able to hear me live or you're able to hear me?
We are able to hear you, sir. Both.
Clear.
So you want me to start?
Yes, sir.
Yes, sir.
Hello. Can you hear me?
Yes, much better, sir.
Hello. Hello.
We can hear you, sir. Much better. We can
Hello.
hear you, sir. We can hear you. Check
I
your.
think sir is not able to hear us.
Yeah, his speaker is not proper. Can you hear us, sir?
Yeah, I can hear you.
Yeah, we can hear you then. If you talk slowly a bit with the Bluetooth, it works.
Ashok, this is going to happen.
Okay.
Can you hear me now?
Yeah, we can hear you, sir. We can hear you. Go ahead. Can you hear us? We can hear you,
I
sir.
lost it.
We can
I
hear
have no
you, sir.
idea what's happening.
So try in Google Meet, sir, then.
Hello.
Sir, we can hear you. I think we can, sir cannot hear us.
Hello. I can't hear you. I have no feedback.
Sir, you're muted.
So sir will log off and restart the laptop and join us back.
Ashok, are you able to hear me?
Yes, sir. We are able to hear you. Can you hear us? Your audio is clear, sir. Can you hear us? Can you hear us, sir? Check the audio and video. Test the speaker and microphone once. Test the audio and video, sir. Audio settings, sir.
Sir, you can share your screen and check once.
Ashok, are you able to hear me?
We are able to hear you, sir. Yes.
But I cannot hear.
Check audio settings.
Yeah, I checked the audio settings.
Your speaker. Check the speaker, sir.
Hello. Hello.
We can
Yes,
hear
sir,
you.
we can hear you.
Okay, shall I go ahead and share screen then?
Yes, sir. You can
Yes.
share your screen and check once.
You can hear us? We can't hear you, sir.
I'm
Now
not.
yeah. Hello?
Can you hear me?
No, it's problem, sir. I think you're connected with the Bluetooth one. Hello? Can you hear us?
Yeah, I can hear you.
Yeah, we can hear you also.
Okay. So I'll put the Bluetooth earphones and
Okay.
I'm not able to hear anything through the Bluetooth. I'm hearing directly through the system.
So that's what, if you change the speaker, not the microphone, then you can set in that the Bluetooth one. Go to
Yeah,
audio settings
I did that. Not working.
So why is it not coming with the Bluetooth device, the speaker one?
I have no idea.
Mhm.
Are you able to hear me?
No, your voice is again cracking a lot.
So this is how it is done. This is how it is going. Answer. Please sort this out and talk later.
No, it is very problem. So one way is if you can connect to the Zoom on your phone also. So disconnect audio from the laptop, connect Zoom on your phone. Your phone will act as the audio device.
No, I haven't done that earlier.
Don't worry, sir. It will work. It works well.
What do you want me to do?
Join on the Zoom on your phone. So you have the Zoom link on WhatsApp. Just
Yeah.
click and join there.
So you want me to join from both sides?
Yeah, but disconnect the audio here. Once you go to audio settings, there is a leave audio computer audio setting. So first you join on the phone.
Yeah, I joined.
Okay, now disconnect the audio here.
Where do I disconnect?
Yeah.
Where do I disconnect?
Audio settings, leave
Yeah,
computer audio.
I've opened it.
Leave computer audio. Okay.
There is no leave. There is no leave computer audio. There is no leave computer audio.
Wait, sir. Just click on the arrow. Above the audio setting, there is leave computer audio. Close the window. Audio above audio setting, there is leave computer audio.
Okay.
Okay, now we can hear you properly.
You can hear me?
Yes.
The volume is good?
Volume is good. Can you hear us?
I can hear you on the
Okay,
phone.
sir. Okay. So your video will be on the laptop.
All right.
And you can share your screen.
Okay, so I'll remove the Bluetooth system.
Yeah, you can remove the Bluetooth. There is no use of that.
All right, so now you can hear me correctly?
Ekdam perfectly.
Chalo, theek hai. So let's start then.
Then you can share the screen.
Yeah.
And you can start your audio also if you want.
Can you see the screen now?
Yes, we can see the screen.
Shall I make it full screen?
Yes.
Is it full screen?
Yes, sir. Perfect.
So we'll start. Sorry for all these problems.
Yeah, now it is perfect, sir. Nothing to worry. It's 100% good.
All right. Okay.
Okay.
So I want one question. On my screen, full screen, I can see the whole panel of Zoom, which says
Right.
join video, stop video. How do I get rid of that?
Okay.
It's blocking my screen.
Okay.
I don't want that panel.
You just drag it out of your screen. It is draggable out of your view. On one on the ends, up or down.
It is not. It stays there.
It stays there.
Anyhow, forget it. Okay. Let's not waste any more time.
Okay.
So yeah, so let me just, I'm sorry for all this mess, and we'll do better, I think, on the next session. We'll have to, today was a bit tight. So why do we need reduction? Understanding the fracture types, the reduction maneuvers, some stability concepts, some pin configurations, special situations, and if you need to open, what do we do? Right? So these are the topics that I hope to cover. So the first concept you must understand in your practice is that why are we treating supracondylar fractures? For a very specific reason, we don't want a gunstock deformity, right? Suppose you don't treat a supracondylar and just leave it. What is going to happen? The worst situation. First, it's an extra-articular fracture. Second, it always heals. Third, it is away from the growth plate. So 90 out of 100 times, even if you don't do anything for a supracondylar fracture, it is going to unite. Second, over a period of time, it is going to regain its range of motion, right? Which is why bone setters are so successful. And people prefer to go to them because they find them cheaper, right? So when a patient comes to you, your only job is to prevent a malunion, for which you need adequate reduction to prevent that varus, and you need a stability so that you don't lose your reduction. Okay. And when you have a malunion, there are three components to it. There is a varus angulation which does not remodel. There is a translocation. There is a translocation which remodels, and there is a rotation which is either compensated by the shoulder or it will remodel to a certain extent. So what you need to do is prevent the varus. Now, the second important concept all of you must understand is that when you see the linear growth of the upper limb, the proximal humerus contributes to about 85% to the linear growth. The lower humerus practically does not contribute to any growth to the length of the humerus. Then what does it contribute to? It contributes to the shape of the distal humerus, the medial condyle, the lateral condyle, the articular surface, the origins of all the flexors and the extensors. So if you understand that growth happens proximally in the humerus and not distally, you will understand that it is not possible for you to get a lot of remodeling if you allow it to malunate. Right? Why I'm coming to this is that our endeavor to treat supracondylar fracture is to prevent a malunion. Simple as that. Now, this paper has highlighted that the limb grows 10 centimeters in the first year of life, 6 centimeters in the second year, 5 centimeters in the third year, 3.5 centimeters in the fourth year, and 3 centimeters in the fifth year. And if you look at the statistics, the maximum incidence of supracondylar fracture happens between 6 years to 8 years. So when the child comes to you with supracondylar, as it is, it has very poor remodeling capacity and very little growth remaining. So older the child, the lesser the remodeling is going to happen. So you cannot really accept a bad reduction, or you cannot expect remodeling to take care of it. So you must have stability so that you don't lose reduction. So a child who is about 8 to 10 years old has only 10% growth remaining. And due to low mean values of remodeling, expecting remodeling in a malunion of supracondylar is practically not possible. So an adequate and a stable reduction is extremely essential to prevent this malunion. Now the second question is, why does the reduction slip? The reduction slips because when the child falls, there is a lot of edema around the elbow. The minute you put the child in immobilization like a slab or a cast, the edema slowly goes away. The plaster becomes loose, and if you are not using a rigid plaster material like fiber cast, within the plaster in a week, your reduction is bound to slip. If the fracture pattern itself is unstable, then you are likely to lose reduction. And if you are going to reduce it without any pins, then there is higher chance that you will lose reduction. So stability and adequate fixation is important. So we need pinning to maintain reduction, optimal early mobilization, and to prevent complication of malunion. When do we need reduction? Now the question always is that when you have a subtle supracondylar, a type 1 or a type 2, do you really need to fix it? Now let me show you some example. This is an 8-year-old girl who came with an elbow injury. This is the X-ray. The treating surgeon thought that this is a simple undisplaced type 1 fracture. There was a fat pad sign here positive, and this was treated in just an above elbow slab. I'm sure most of you in medical colleges would be doing the same thing. We would be treating this kind of an innocuous looking fracture with a plaster slab, and the next thing you know is that it collapses into a malunion. And then you worry that, this was a simple fracture, why did it go into malunion? You have to understand that when you see medial combination, especially in an older child, your tolerance should be very low. You cannot accept this kind of bad deformity, and the parents will never be happy with you. If this is the treatment that you offer to your child, what is the difference between you and a bone setter? Our job, like I said, is to prevent a malunion. Now, this is another example, a type 2 fracture with a medial comminution, 9-year-old child. Again, this was treated conservatively, and you can see the amount of varus. Second thing you must remember, every child who has hyperlaxity syndrome will have recurvatum, and recurvatum exaggerates the varus, right? It is also one of the reasons why a person gets a supracondylar. On an extended elbow, when the child falls with an extended elbow on the palm, the hyperextension in the elbow causes the impingement of the olecranon fossa. The proximal ulna breaks the supracondylar region. That is why the fracture happens. So typically, if you have a child who has no recurvatum and he falls on outstretched hand, he will break lower radius. If he has recurvatum, because of laxity, he will break the supracondylar region. That is what is commonly observed, right? So the adequacy of reduction is extremely important for having a satisfactory outcome. And nowadays, even type 2 fractures have been subclassified. It is given in Rockwood, the new edition, that Wilkins and K. Wilkins has classified type 2 into rotationally stable and rotationally unstable. And the best way to approach these fractures is by reduction and pinning. Okay. And type 3, obviously, a type 3 is a completely displaced fracture. Trying to put it in plaster and reducing it like this is not really a good idea, because you have no control over the distal fracture. And you can end up with a really, really bad kind of a end up with a bad kind of a stiffness as well as a malunion. So that is not what you want to achieve. Like I said, we are not bone setters. So when you do pinning, it's always a hit or a miss. A lot of patients we see, I get a lot of referrals from all over Maharashtra, and the parents say that आमचं operation तर झालंय, they have done a fixation. Okay, you have only one chance of getting a good stable fixation. Pinning like this is not really, putting pins and putting multiple pins is not the answer if you know what to do. Now this child, 3 pins have been put, all of them are only in the proximal fragment. The distal fragment is not engaged at all. Okay, this is the kind of things that we don't want you to do. Now this child was, again, supracondylar was treated with a cross pinning, because you've been taught that cross pinning is supposed to be more biomechanically stable as compared to lateral pins. So they said cross pinning. But if both pins are crossing at single point and they are crossing at the wrong level, they have absolutely no stability. And look at the lateral view. The pin is not actually in bone at all, right? And you end up with a bad result. Another example, supracondylar. Look at where the pins are. They are just lying in soft tissue somewhere. One has migrated out. And you can see, can you see the gap between the skin and the POP? The plaster has loosened and slipped up, and the pins have become loose. So all of you, those who are using slab, please be very, very careful. Slab of plaster of Paris is not such a good idea for stability. This is another example. Pinning has been done, but the reduction is not good. And if you see, this is not bicortical. It is an intramedullary pin. So this is again not giving stability. So how you pin is also important. You cannot pin in any which way and say that it is okay. So it is not very difficult if you understand what to do. Okay, and I have my friend Taral who has also contributed a few cases. The problem with most of us is understanding the fracture pattern, looking at whether there is comminution. So when you see an X-ray, you must look at the fracture pattern and first identify whether there is comminution. Second, you must decide how you are going to tackle the swelling. Third, how do you assess stability after your reduction? And do you need pinning? And after pinning, how do you assess stability? Fourth, you must know what is blocking your reduction. Fifth, and what is the technique that you are going to follow, right? So it is like cricket. You must have a good field placement. Your OT arrangement should be such that your OT monitor is right in front of your eyes. Your trolley is next to you so that you can access instruments, and the C-arm should show you the elbow very clearly. A lot of people have their own way of positioning. People use a long board and then a folded sheet underneath like this, so that you can access the elbow all around for your pinning. But I have always found that this extra length of table comes in the way of the surgeon and the drill when you're doing your pinning procedure. So my way, I've published this enough number of times. What I do is that after I inspect and check the patient, so this is an example. I'm checking preoperatively finger motion. This is always to be done. It's not a good idea to come out of OT and later post-op find that finger is not moving, and then you don't know whether it was pre-op or it is because of your pin. So always examine the pulse as well as the finger motion, and make the child do thumb extension in the OT before you start the procedure. The second is putting this arm board. This is my arm board technique, where we put the arm board and position the child to the edge, and then we strap the proximal fragment. You just strap the proximal fragment to the proximal part of the board using a white simple cotton sticking plaster, a broad 3-inch tape, so that you hold the proximal fragment to the board and you don't need any assistant giving counter traction. Once that is done, you are free to do your reduction. Okay, then you maneuver the distal fragment, give a traction, longitudinal traction. If the spike is anterior, you have already put the tape, just flex it, adjust the varus valgus, okay, and then you can turn the C-arm around. You don't need to really turn the arm. You just turn the C-arm, right? So you take an AP view and then you take a lateral view. A lateral view is done with the C-arm turned around, right? So when the C-arm is turned around, you can get a dead lateral view. And then the entire elbow after preparation and drapes on it is available to you circumferentially, so that you can pass your pins very, very easily. Again, you can see I don't need an assistant. And this is very easily and very simply done. And then you can just bend the pins and cut them off and give your plaster cast, right? Even after fixation, I prefer to use a soft cast, so that it accommodates swelling, and I can easily remove it when the time comes for removal of plaster. So this is, you cut the pins and then you do your plaster. So in a standard supracondylar, something like this, what you need to do is understand that what is meant by the collapse. If you see the pillars are flat bone below which there are condyles. And if the pillars don't sit on top of each other, they will collapse into varus. So the column views are very, very important to check the stability of your reduction. You take internal and external oblique views so that you see the columns correctly after your reduction. And remember that if your columns are not sitting on top of each other nicely, the minute there is malrotation, they are going to collapse into varus, right? So the collapse into varus, the malrotation does not matter for malunion, but malrotation matters because it causes a varus collapse, right? So it is very, very important that you put it correctly. What about the pin placement? For a long time, people have talked that cross pinning is supposed to be superior compared to lateral pinning. But biomechanical studies now have shown that if you put a stable fossa pin, so your pins have to be one in the pillar and one in the fossa. When you put a fossa pin, the pin goes from the lateral cortex out through the olecranon fossa, then back into from the cortical bone on the fossa and out from the medial side. That pin is called a forecortex stable pin, and that gives you very good hold and stability, so that you don't need to rely on cross pinning, because the single largest cause of litigation is causing an iatrogenic ulnar nerve palsy, right? So the two common causes for litigation in America and nowadays also in India are creating a compartment syndrome, and second, hitting the ulnar nerve and causing an ulnar nerve palsy when none existed. So lateral pinning, if it is stable, is a superior way rather than going for medial pinning, right? So the things have evolved. Initially, Lee had described in 2002 column pins, 2 column pins to give stability. And then the concept came that divergent pins are better. So as you can see, if you divide the lower humerus into 1/3 and 2/3, your pin should be crossing at junction of 1/3 and 2/3. They have to be bicortical, and one of the pins should be from the fossa to the fossa and out. And the second pin has to be pillar. So divergence has to be there more than 45 degrees. And David Skaggs published that if there is still instability on rotating the arm, you can add a third pin, right? So a standard pin fixation, this is a cross pin fixation. If you are using cross pins, the crossing of the pin should be above the fracture. The crossing should be in the metaphysis above the fracture. The pin has to be bicortical, and the medial pin has to be anteromedial to posterolateral, so that you avoid the ulnar nerve, right? K wire should be above the fracture. Medial wire should be anterior to posterior. This is what I prefer, a 2-pin configuration where you have a pillar pin and a fossa pin. Both are bicortical and crossing the fracture at 1/3 and 2/3. That is what is recommended, which makes it about 8 millimeter distance between the 2 pins minimum, with a 1 forecortex pin. So this is a forecortex pin. As you can see on the video here, the pin is going from the lateral condyle into the fossa, then through the fossa and coming out on the medial side. So theoretically, you are actually blocking the movement of the elbow, but remember, the pin is here only for 3 weeks. So you have to get the pin out and then mobilize. So it doesn't matter. Okay, when there is instability or comminution, an additional medial pin may be required as shown here, but make sure it crosses in the metaphyseal region. This is a Dorgan's pin. Some people had tried that rather than putting the medial pin from distal, proximal to distal, they said let's go from the shaft and towards the condyle. Now that seems to be safe for the ulnar nerve, but sometimes you might hit the radial nerve here, right? So a proximal to distal pin can be done. It's called a Dorgan's pin. He had described this pin, but it can be dangerous and can cause ulnar nerve paresis. Okay, so a standard forecortex fixation should do the job most of the times. There are a few indications where medial pin is mandatory. And what are those? These are when you have an oblique fracture. So like I said, we assume that every fracture is a supracondylar transverse fracture, but many a times it may be a oblique fracture, and an oblique fracture which has a large chunk of the medial condyle will need a pin which goes from the medial side, because your lateral pin will have hardly any hold. So you must make sure that you have a good medial pin. Instability after lateral pinning is another indication to use a medial pin. An oblique fracture and medial comminution or impaction. If you see there is medial impaction, you must disimpact it and use a pin to stabilize so that it doesn't collapse again, to prevent the varus malunion. If you're going to do medial pinning, you must learn how to do safe medial pinning. And safe medial pinning is always done in about 30 degrees of extension. So you don't flex the elbow. You have already put a lateral pin. There is relative stability. Then with your thumb, you push the ulnar nerve behind. Okay, and you walk on the bone. When I mean walk on the bone is you take the K wire in your hand and manually puncture the skin and make sure you are right on the medial epicondyle anterior. Then you attach the drill to it. Okay, and make sure that you are going from anteromedial towards posterolateral, and the thumb is pushing the ulnar nerve behind so that you don't entangle the sheath of the ulnar nerve or doesn't cause any entanglement of the fascia which surrounds the nerve. Okay, so if you palpate your own elbow and flex the elbow, you will feel the ulnar nerve coming anterior, and when you extend the elbow, you can see it goes back into the groove for the ulnar nerve. So make sure that the medial pin goes, if you need to do it, it's always in 30-degree extension. So feel the medial epicondyle, feel there is no nerve there. You don't need to dissect the nerve. You just make sure that where you are putting it on bone, there is no nerve or nerve sheath, so that when the drill rotates, it doesn't entangle the sheath. Always use a drill sleeve so that again you protect the fascia from getting entangled. And if there is a doubt, make a small opening. Make sure there is only bone there, and you can go ahead and pass your medial pin. Oblique supracondylus. Now this interesting paper by Bach is what I was alluring to earlier. We think that every supracondylar is a transverse fracture, but Bach described these 4 patterns. You can have a low supracondylar, you can have an lateral oblique supracondylar, you can have a medial oblique supracondylar, or you can have a high supracondylar. And each one has its own peculiarity. The low supracondylars usually are so close to the end arteries of the lower humerus that chances of avascular necrosis are very high, and you must be very aware of this complication. So when you see a very low supracondylar, something like a transphysial, you must warn the parents that there could be a chance of a AVN. If there is a lateral oblique, it's a standard fracture. You can put all pins laterally. A medial oblique needs a medial pin, and a high supracondylar, you may need to pass an intramedullary pin. So a transverse fracture is stable, and you can do standard pinning. But on the lateral, if you see an oblique fracture like this tends to glide or slide. So this will need a perpendicular pin, right? So your pinning has to be accordingly adjusted. So this is a large medial chunk. You can see that supracondylar fracture with a medial displacement. A large medial chunk obviously needed a medial pin. A cross pinning has been done. And a large lateral fragment here, you can use only lateral pins, right? High supracondylars like these with comminution, these metaphysiodiaphysial fractures again may end into varus malunion. So it is important. They may be easy to reduce, but your pin tends to go intramedullary. Because of the high nature, metadiaphysial, one pin has to go intramedullary, right? You may not be able to engage the opposite cortex. So make sure that the pin goes high enough to engage the intramedullary canal. Now this is an example of a comminuted complex proximal, metadiaphysial fracture, which I have put a pin right up to the neck of the humerus. Right, so you can use really long pins which go intramedullary, or you can even use elastic nails in this situation, going from the deltoid insertion and coming retrograde. Right, so this is how it heals. Very low supracondylars like this, you must be aware that you may end up with trochlear AVN. Okay, there are 2 types of AVN, A and B. A is where the medial part, that is the trochlea, is involved. B, the lateral crista, is also involved, and you can have a really bad elbow. Adolescent supracondylars are of high intensity trauma, and they have to be treated more like adult supracondylar TY elbow. So putting a lot of pins like this may be okay, but it causes a lot of callus reaction which may block motion. So sometimes instead of doing this, it may be easier that we put a plate. So plating, a pillar plate may be safer and simpler in an adolescent age group, rather than trying to put pins, especially if it is metadiaphysial. And that is how it will heal very nicely without problems. Now, sometimes you have the Gartland 4 injury. The Gartland 4 injury is where you get the anterior periosteum also getting torn. Now, these fractures are very unstable because when you try to flex, they get over-reduced. A joystick method is where you need to use a small pin to maneuver the distal fragment. So this is an example where you can see that this fracture seems to be an extension fracture, but when I flex it, it goes into flexion. This tells me that the fracture is getting over reduced. That is because the anterior periosteal hinge is also torn, and this is extremely unstable. So what you do is you pass a pin just going up to the fracture fragment, and then use that as a lever and bring it into alignment, and then use that, look at AP and lateral both, get your alignment right, and then pass one pin and stabilize it, and then go ahead and pass all your other pins. This maneuver can also be used in another interesting fracture type, that is the flexion supracondylar. The flexion supracondylar also can be troublesome because you have to reduce it in extension. So what you can do is put a pin going from the olecranon into the distal fragment and bring that distal fragment into extension from flexion, so that you make it straight, and then go intramedullary. You have a temporary fixation, and then with this you can put your one lateral pin, then you can remove this pin and put the second lateral pin. So you can use a joystick maneuver for these things. How do you tackle the swelling? The irreducible supracondylars, you use the leverage technique. So in the leverage technique, if you're not getting reduction, you can use an intrafocal manipulation. Take a K-wire, put it on a T handle and enter the fracture site, and then lever the fragment into its corrected position. You can see here, I've used a K-wire, I've pushed it into the fracture, and then I've levered the fragment down. When you lever the fragment down like this, as you are seeing in this clinical picture, after it comes into acceptable position, then you reduce it and pass your pins. There is one more method which has been published to tackle the swelling, and that is called the suction cannula technique. Now this child with an extremely swollen elbow, extension supracondylar fracture, widely displaced, what was done was a small nick is made in front of the humerus. Use a suction cannula, connect it to the suction so that the hematoma is drained, and then the cannula is used like a lever to push the fragment back. Against this, you can give traction and reduce the distal fragment, and then you can pin it. Okay. So my supracondylar method of using the arm board takes care of this problem automatically. Here they have used a suction cannula to do that, and then they have done cross pin. Okay, this is published in Acta Orthopaedica in 2005 by our colleague Viraj from Nagpur. And this is again, sometimes in our country, what happens is that every patient doesn't come to you on day one. They come late. And when they come late, you're always in a dilemma. Should you touch it, or you should do open reduction, or you leave it alone, right? So for our philosophy is that if there is soft callus formation, and if this is less than 10 days old, and there is no history of massage, what you can do is you can use a leverage technique using an artery forceps. So this child who had come with this kind of a fracture, and this was the sort of a reduction which was attempted outside somewhere, was done under GA, and a slab was given and sent off. They came after 8 to 10 days with blisters and this kind of picture with a displacement. Now what can be done, because there is soft callus and you don't want to open because you may cause myositis. So what can be done is you use an artery forceps. Use a small nick in the posteriorly in the triceps, and then put a artery forceps with its angle going downwards, and then lever the fragment, turn it around, hitch it against the proximal fragment, and then bring that back and pull it. So this is how you can do it. You can see this maneuvering being done from behind. Okay, you need a little experience to start doing these techniques, but if you master them, each and every supracondylar fracture can be treated without open reduction. I haven't open reduced a fracture for 15 years now. You can see that there is one K-wire to control the rotation of the proximal fragment. The surgeon, this is Dr. Taral's case, he has put the artery forceps into the fracture, and then he has turned it around and he is hitching it against the medullary canal of the proximal fragment, and then with gentle leverage and flexion, see how he brings that fragment down. And with the upper pin, he can control the rotation. And then when he gets a satisfactory alignment, he passes the pin. Okay. Now, as I said, when you have a mal rotation and you have no control over the proximal fragment, put a small pin in the proximal fragment so that you control that anterior spike. So put a pin there and derotate it so that you can get more control over what you're trying to do. So these small techniques will help you to achieve really an excellent reduction. See that K-wire is being used to derotate. Okay, so when you derotate, you can see how nicely it comes into alignment. Otherwise, you were seeing that this proximal fragment was being seen like an AP view and the distal fragment was like a lateral view. So control over the proximal fragment with a rotation wire, and then you put your pins, right? This is how this treatment was done. That was post-op and that healed. Now, whenever you see a pucker sign like this, a pucker sign tells you that the spike in front has pierced the brachialis and is lying just under the skin. There may be chance that median nerve or the vessel may be entrapped here, and that is a sign of irreducibility. This is the pucker sign. So that tells you that you might need to do open reduction. Extensive bruising also tells you that there is likelihood of an open reduction. And beware of the spike angle. So when you see that the skin tip distance is very small or the angle is very acute, the likelihood of requiring open reduction increases. This is what has been published. The medial corner angle less than 45 or the skin tip distance which is very small, you should be ready for an open reduction. So you plan preoperatively what is going to happen, and then when you want to do an open reduction, remember doing a posterior approach and tricep splitting is no longer the way to do an open reduction. Just make a small incision where the anterior spike is. If it is anteromedial, the incision is anteromedial. You just gently go around the spike and take care of whatever soft tissue is getting entrapped. Sometimes it may be the brachial artery and the median nerve, or sometimes it may be the radial nerve, depending on where the fracture fragment has displaced. And then once that is milked out by your finger dissection, you just slide that proximal spike back into its position and then reduce it. So it's actually a assisted close reduction, but never do a posterior open reduction. Okay. So indications of open reduction are failure to obtain a close reduction, failure to maintain a stable reduction, or a primary neurovascular compromise, right? So a midline posterior approach causes a lot of triceps adhesions, fibrosis in the olecranon fossa, and you cannot have a judgment when the child is in lateral position. So it's better that you avoid this approach, which has been traditionally taught, and go for an anterior approach. So the anterior approach is to remove the interposed structure, get a close reduction, and pin it percutaneously. The surgical approach for a posteromedial fracture, when the fracture is posteromedial, the spike is anterolateral, right? So depending on where the spike is, you take the incision, and whatever is in between, just take it out and then do reduction. For a posterolateral fracture, it will be the radial nerve. So get the radial nerve away through an anterolateral incision, right? And then you do your reduction. So the need for open reduction may be determined by soft tissue interposition, your experience with close reduction techniques, the fracture pattern. So for type 3, type 4 supracondylus, close reduction and pinning is the way to go. Anatomic reduction is expected or should be ideal. If not, at least an acceptable reduction for a good outcome. If you fail in close reduction or if there is interposition, you can try the percutaneous minimally invasive techniques. Or if there is a primary neurovascular complication, an open fracture, swelling which is disproportionate, or you are working in a peripheral hospital, you don't have experience, there is no CIAM, there is no IITV, go for a open reduction, reduce it nicely and pin it. That is totally acceptable. And open reduction does not really affect the outcome in the long term, and they have good probability of excellent results and low poor results, provided you do it very nicely and safe. So I'll stop this presentation here and I'll take some questions from everybody. And we will talk about more about supracondylar after we take questions.
Dr. Sandeep,
Yes.
Dr. Nitin Patel here.
Yes, Nitin sir.
Yeah. You talked about the flexion injury
Yes.
manipulation by putting a wire through
Yes.
olecranon.
Yeah.
I didn't get you that.
Okay.
If it breaks in the joint, then it will be a problem. No? If try.
No.
while
So
doing
that's
the
what I'm saying. What happens, Dr. Nitin, is that when there is a flexion injury, distal fragment being in flexion, there is very little space for you to maneuver that fragment. When you flex the elbow, I'll just try to show you. When you flex the elbow, transolecranon, you can put a K-wire which goes across the joint into the distal fragment. And with that wire, you can extend it so that the leverage is more better. And then in this, it's a central wire which goes from olecranon into the distal fragment, transarticular. When you extend and get your reduction, pass the wire intramedullary. A thin 2 mm wire allows you sufficient play for you to adjust the mediolateral alignment on the AP after you do this. And when you get the reduction, then you pass your lateral pin and take out this wire. Don't leave it in. And then you pass the second lateral pin. So that is how you achieve that reduction.
Okay. You mean the distal humeral fragment along with
Olecranon. Correct. As a single piece.
Move.
As a single piece. That is just to allow you to maneuver it a little better. And then when you get your maneuver, you extend it. The flexion injury, you extend it. Pass that pin intramedullary. You can do this even on a T-handle chuck. Once you get that, put the lateral pin to stabilize and remove this pin.
Okay.
So you don't leave the pin inside.
Okay. Thank you.
Yeah. Gopendra Singh, I think you have raised your hand.
Yes, sir. Sir, in which view you put the first pin? In which view of C-arm? Means in AP view, if we, lateral view.
Yeah, the first pin which I put, because I'm doing my arm board technique, if you want, I'm going to run a video again for you. I'll share screen.
Yeah.
And I'll run the supracondylar arm board technique again for you.
Sir, with your kind permission, I presented in Chhattisgarh this your arm board technique, if you remember, in my presentation. Yes, sir.
Can you see?
And I'm presenting to you.
No, sir.
Are you able to see?
No, sir.
No, okay, let me, where is that now? Ashok? My panel has disappeared. How do I get to the panel?
Actually, I am using your arm board technique, sir. And in one of my presentation in Chhattisgarh, I presented this arm board technique of yours. And I asked you.
You are able to do it?
Yes, sir. Yes, sir. I'm able to do it. But I want to know your technique means how do you put first pin in AP view or lateral view?
I will show you. I'm just trying to. Ashok, technical support, who is there? Ashok, Neeraj, who's there from OrthoTV, please?
Yes, sir.
I am not able to see my control panel for sharing the screen. How do I get to that? Hello.
Sir, we are able to see your screen.
I know I am not able to see on the this thing. I had disabled the video panel.
Okay.
How do I get it back? It's a feature of Zoom. Does anybody know that was blocking my screen? So I had disabled it. Does anybody know how to? Okay, I've got it. I've got it. So I'll share the screen again. Okay. Can you see now?
Yes, sir.
Okay, I'll run it then.
Technique for close reduction and pinning supracondylar fractures injury. We have no disclosures. There is no commercial support or any funding for this video. Conventionally, supracondylar fractures are reduced and pinned in the following.
So conventionally, you know that I showed you how people do supracondylar fractures. Okay, can you hear me?
Yes. Yes, sir.
Yeah, but putting the elbow on the table makes manipulation a little difficult.
Yes, sir.
And that table comes in the way. This is what I was saying. Some people try to do reduction on the C-arm tube, but all your cleaning solutions can damage your equipment, cause short circuit. So again, that is not a very good idea. Some people do lateral position, but lateral position reduction, again, getting orientation of varus valgus can be tricky, right? So
Yes, sir.
assistant and traction issues are also there. So that when you try to rotate to see the lateral, your reduction slips. So these are the problems with conventional methods. So this is an example. Just see that type 3 supracondylar with a pucker sign. Right?
Yes.
This
Yes, sir.
child had a large amount of bruising in front of the elbow, and this is how the child presented. Fortunately, it was a pink and a pulseless hand. This is a arm board. It's a standard wooden board which you can manufacture in your own OT. A carpenter can just cut a board for you. It should not be too long. Always check the capillary refill. Now this is how I position it. I hope you are able to see.
Yes, sir.
You can use a hypoallergenic micropore tape. Make sure that the fracture is distal to that and only the proximal. And then with a gentle traction and milking maneuver. This is milking maneuver, so that I have been able to push that fragment back under the brachialis, right? So that puckering is gone. Now that the puckering is gone, you check the AP alignment on the C-arm, and then you rotate the C-arm 180 degrees and check the lateral. Now I have flexed it. Once I flex it and I get my reduction, see, you can see that on lateral, the lateral view looks pretty good. Now this is locking my reduction, and I have the entire elbow free. Then I prepare and I put a small hole sheet like this. And then I don't have any assistant. I'm just holding it on the lateral profile, 45 degrees angulated. My first pin goes from slightly anterior to posterior because the distal humerus is 40 degree anteriorly tilted, right? And then I turn the C-arm to see the AP view. Okay. And this is now relatively stable because one pin has already gone in. It's not absolutely stable.
Yes, sir.
The second pin goes parallel to it into the pillar, and with flexion, we stabilize it again. That artery forceps is just to prevent impinging. So now two pins have gone. One is a fossa pin, one is a pillar pin. Now I can rotate it manually to check rotational stability. So this allows me to take column views also, and it allows me to rotate the arm. Because that paper tape is not strong enough, it's just to hold it. And then I just use a suction cannula. I bend the pins and then I cut them off. And then the casting is done. So the whole procedure doesn't take more than 10-15 minutes. Okay, once you get more and more fluent with it, you will enjoy doing this very easily. And then I use a fiber cast tape and always check for the post-operative capillary refill. Right? And then you finish. Yep. So that is the final imaging on AP and lateral. And like I said, this becomes pretty easy most of the times and is not really a big problem.
Yes, sir.
So that is about the onboard technique. Yeah, somebody, Nitin Patil sir, another question?
Yeah, recently I came across a low supracondylar fracture in a 6 or 7 year old boy.
Yes.
And the fragment was displaced anteromedially.
Correct.
And it was not possible to reduce it closely. So much I tried twice or thrice. And when I opened that, the anterior capsule was intervened between the two fragments, and then ulnar nerve was also transposed in between.
Correct. So when you say that it's an anteromedial, no, sir, that is a flexion injury.
Yeah, flexion injury.
So flexion injury, again, like I said, flexion injury is a little tricky to handle. There are 2 pointers which should make you suspect a flexion injury. One, this is the only fracture where you get ulnar nerve symptoms preoperatively. They'll say numbness along the little finger, you should specifically ask for it. Second, when you take a lateral view, you will see distal fragment rotated and the spike into the medial side of the fragment, like you said. And
Correct.
there may be interposition of the ulnar nerve and capsule, and it is difficult to reduce. So what you did
Yeah.
is perfectly all right. Your incision should be placed on the spike, remove that ulnar nerve gently, push it back, and then pin it. That is
Yeah.
absolutely correct what you did, and it's safer if you are not conversant with trying the transolecranon pin or trying to reduce it in extension.
Yeah, I
It
have
can
not
be
tried
tricky.
it till now.
Yeah,
I will
yeah.
try
So it's
next time.
something. I'll demonstrate that to you in another talk. Yeah.
Okay.
Who is iPhone? Somebody has
Yeah,
raised
hi,
hand.
sir. Hello, sir.
Yeah.
Pradeep here.
Yeah.
Sir, one thing. So, for posteromedial fragment, usually we give traction and flexion with thumb in internotation, I mean, making the pronation and supination.
Okay.
So, first question is on X-ray, how to find out is it posteromedial or posterolateral?
No, on a
So,
plain X-ray, you will be able to make out.
so that is the one question only.
Yeah. Yeah. On a plain X-ray, on an AP, you will know whether it is medial or lateral. And
Okay.
on the lateral view, it tells you whether it is extension or flexion type.
Lateral flexion extension is okay, but most of the is extension type only. Out of that, most of them are posteromedial only.
Yeah, but
90%.
you can also see posterolateral, you can always get if you suspect, see, depending on the nerve injury also.
Okay.
If
A
there is a
patient having
nerve, yeah, if there is a nerve injury, the posteromedial fragment, the spike goes anterolateral, so you'll get radial now.
okay.
That
If
is
patient
another
is not
point.
having any inner injury that
There's
time.
no, then you have to just check on the AP view and the lateral view. That is all.
Okay. In AP view, we'll see spike on.
You see the spike, which side it is.
Okay. Fine. Okay.
Right. Any other question?
And how much rotation actually, in case we have to accept, because most of the time.
So again, I will just remind everybody that see the rotational malalignment for malunion doesn't matter,
Okay.
right? When we say that I have a cubitus varus with a internal rotation deformity, right? The internal rotation or external rotation malunion can get compensated because shoulder has a lot of rotation.
Exactly.
But if your rotation is not correct, your pillar to pillar contact is a problem. And if the
Okay.
pillar to pillar contact is not correct, then in mal rotation, it collapses into varus.
Yes.
So the rotation on table needs to be correct to prevent varus collapse before you pin it. That is the only reason why you talk so much about rotation and getting that K-wire. Like I said, you put a shaft K-wire and derotate the proximal fragment.
Okay.
If you
Okay.
cannot control the distal fragment, try to control the proximal fragment.
Okay.
Yeah,
So
that
if
is
you
the
strap the proximal fragment, then
yeah.
how to manipulate without K-wire?
So
Because we
no,
are
no,
not
this
using strapping. We are.
understand. I understand. So that's what I'm saying. People who are using the onboard technique will not face this problem because the proximal fragment is already strongly immobilized.
Okay. So only
You
distal
can
fragment.
control only the distal fragment, rotate it either ways, and you will be able to do it.
Okay.
If you are doing the conventional methods and not using the onboard technique, then you can use a pin. All these methods which are done are by other people. I haven't had the need to put anything of that sort.
Okay, sir. Thank you, sir.
May I?
Yeah, please ask.
In our residency days, we were taught that if in extension type of supracondylar fracture, if the reduction is perfect,
yes,
then only cuff and collar should suffice because of the buttressing effect of the tricep used to not to get dislocated or subluxated.
Yes, sir.
Does that stand true today?
No. So I'll just answer that. When I studied Patil sir, I was also taught the same thing. That when you do a reduction in flexion and your posterior triceps hinge becomes tight, you either pronate it to lock it so that it doesn't move and just give a plaster slab. But there are two problems with this. A type 3, when you are acutely flexing it, the edema in the cubital fossa may cause blistering wounds as well as a lot of compartment issues. Second
Okay.
problem is that when you give a slab, a back slab, within a week, when the pain reduces, the child starts moving and the slab can become loose and the fracture fragment may displace. Like I said, the tolerability of people to accept a slight varus malunion was very high and litigation rates were very low.
That time.
The
Yeah.
whole world has moved away from that, and unfortunately today parents refuse to accept even a bad quality plaster. So
Yeah.
I'm not saying what we were doing is incorrect. What I'm saying is times have changed.
Okay.
Even today we can manage if you are in a peripheral area, if you put Dunlop traction, put the child and do gradual reduction, so that lot of swelling is there. People used to put a little traction and accept a little extension and then gradually flex it in the second plaster and third plaster as the edema subsides. Like I said, sir, the only purpose of doing an accurate reduction is to prevent varus collapse and malunion in varus. Everything else remodels.
Okay.
So there was a time when we were doing bed rest and traction treatment for all intertrochanteric fractures also. Today that is no longer true. Similarly, for supracondylar fractures, with the society becoming more and more aggressive, litigations happening because of malunions, it is safer that we don't treat supracondylar just with a plaster. And in residency, hardly anybody went and saw the patient after 3 months or 6 months, whether he got cubitus varus or not. It was thought that all children's fracture heal hota hai or remodel hota hai. That is not true, sir. The younger generation needs to be more alert and aware.
Is the remodeling better in closely treated fractures or the fractures treated with KYS?
No, remodeling is not better or worse. I pointed out in the beginning of the talk that remodeling potential is very low in supracondylar region because of less growth. What happens is that the stability of reduction is much better when pins are there rather than no pins. And your assurance of maintaining your reduction is much superior. If you open reduce, the chances of causing stiffness are higher.
Right.
So if you do a close reduction and natural healing, the callus formation is much better, quality of bone is much better, and they will have lesser stiffness rather than opening and reducing.
Okay. Thank you.
May I, sir?
Yeah.
Sir, you told the distance between the pin is 8 mm and angle is 45 degrees. So
Yeah.
I didn't get it, sir. Like from where you measuring the distance?
No. So the distance, if you calculate the width of the distal humerus where it is fractured, your one pin must go 1/3 of the diameter. The second pin should cut at 2/3 of the diameter.
At the fracture side, sir.
At the fracture side. So if you do that, the distance between the two pins will be minimal 8 millimeters or more.
Oh.
There are different ways of describing the same thing. If your distance between two pins is less than 8 millimeters, it means those two pins are very close to each other and working like one pin. That means divergence is not adequate.
Oh. So
Okay.
if it's diverging, it should be 45 degrees, sir, with respect to each other.
So first pin, what you do is that when you're putting your first pin, if you go at an angle between 45 and 60, you always go through the fossa.
Okay.
When that pin goes through the fossa, the second pin, if you make it through the pillar, you will have a perfect fossa. So what we always tell everybody is that go for one pillar pin and one fossa pin.
So first you suggest to put the fossa pin, sir.
Correct.
Next one
Because
is pillar.
at 45 degrees will go straight through the fossa.
Oh.
And then you go for the pillar pin in AP view. On the lateral view, you are going through the fossa.
Sir, how long you suggest to keep the pin, sir?
Yeah, so that is a good question. A supracondylar fracture, usually in less than 8 years of age, I will use the pins for three weeks. After 3 weeks, in the OPD, I will remove the pins and continue the sling and start gentle range of motion. In 8 years and above, I will remove the pins after 4 weeks. Okay. leaving the pins longer than that is not required because adequate callus forms in metaphyseal fractures, and leaving the pins longer than that may cause loosening of pin, introduction of infection, and especially one pin is going intra-articular through the fossa. We don't want to end up with septic arthritis. So try to remove the pins younger than 8, 3 weeks, or 8, 4 weeks, not more than that. Whereas in lateral condyle, we always use the pins for minimum of 6 weeks and till we see radiological union, not before that. You should not remove it.
Which one, sir? Could you repeat last sentence?
Lateral condyle is different, I said. Don't use the same philosophy in lateral condyle.
Sir, while putting the cast after the pin fixation, you
Yeah.
will keep the slab in more than 90, cast in more than 90-degree flexion?
No. When you are doing the reduction, acutely you are flexing more than 90. Once your pins are in, you have stability. You always make it to about 70, 80 degrees. Your flexion crease should be free. That is the whole purpose of pinning. If you are still going to cast in acute flexion, there is no point in giving pins, which is what Dr. Patil was saying. We used to acutely flex, pronate, and give a slap like that. The purpose is to avoid blisters and compression and compartment syndrome. So you can extend it then. Your pins are holding the reduction.
Sir, could you talk something about varus malunion, sir? How to treat it, and osteotomy, when to do it?
Yeah. So varus malunion, which is the commonest problem as a complication, should be treated. Normally, people used to say that the child should be operated at maturity, right? That is not true. Maximum remodeling, whatever remodeling has to happen, and whatever stiffness has to be taken care of by active range of motion, will be over by 1 year. Okay, so you can do your osteotomy safely after 1 year of allowing the malunion to at least remodel a little bit, the rotation as well as extension, and the varus will need to be corrected by an osteotomy in the supracondylar region. So 1 year of waiting is adequate. It is not necessary to wait till maturity. Within 1 year, you will also find out if there is avascular necrosis, which is why you don't go for a very early varus correction. Because if you are osteotomy, after your osteotomy, you may get a recurrence because the medial trochlea went into AVN and did not grow, and lateral kept on growing, and then you get a recurrence after osteotomy. So 1 year is the golden mean where remodeling is over, stiffness is gone, and you know whether there is some kind of AVN happening on the trochlear side. So 1
You
year
suggest MRI before operation, sir?
No. MRI is not necessary for making that diagnosis. You can look at an X-ray. You will see fragmentation and change in density on the trochlear side if there is AVN. Secondly, AVN is not a very common occurrence. You should know that it can happen, but it is less than 1% to 2%. So you cannot keep on doing MRI for every person for cubitus varus correction pre-operative. Don't overuse the investigation also.
Sir, you prefer open osteotomy or closed osteotomy, sir?
So lateral closing wedge, I use an oblique osteotomy with equal segments so that there is no step, right? I use an osteotomy which allows me closure on the lateral side. I'm just trying to find a presentation to show you.
How do you decide, sir, how much bone to take out?
So that's what I'm trying to tell you. Yeah, so I'll show you. See this. I'll run through this presentation for you quickly. Okay, we have time. I'm sure you have time, no?
Yes, sir.
Yes.
So I'll just share this presentation so that everybody is clear on what I'm trying to tell you. Yeah. Can you see the screen?
Yes, sir.
Yes.
Yeah. So complications, like I said, malunion, stiffness, and VIC. Why do we correct angulation? Varus does not remodel. When does it happen? Medial green stick collapse, unstable in internal rotation type 2, and poor reduction, poor fixation, or untreated. So this is example of a type 1 with a medial collapse which ended in varus, bad fixation ending in varus, and you see bipillar thickening, gunstock deformity, and classic deformity. Yeah, X-ray, you see this. Can you see this increased density of the trochlea here? Are you able to see?
Yes, sir.
Yeah, so this is good enough for you to make out that this is AVN. Okay, with the varus, there is an AVN here. So this is a difficult situation, right? We have to, it's not a cosmetic deformity. When you have a cubitus varus, the elbow is working at a disadvantage. When the child has a fall next time, he'll get an intra-articular lateral condyle fracture. Second, this is an example. This child had a cubitus varus, he fell, he got a lateral condyle. Okay, because of the varus. So that is important. Okay, this is his 1 year ago X-ray. He had a supracondylar which was treated like this, unstable fixation, healed in varus. Okay, you see the pins have backed out, right? This is how he was treated. And then the wires were removed, and you can see that it has collapsed into varus, and he ended up with a cubitus varus. And then he had another fall, and he ended up with lateral condyle. So then I had to fix the lateral condyle. This is an arthrogram showing you the dye going into the lateral condyle fracture. Then we did a close reduction and a percutaneous screw fixation to treat the lateral condyle, and later on we had to do an osteotomy. So this is a known complication. You don't call cubitus varus only as a cosmetic deformity. Secondly, you can have posterior lateral rotary instability of the elbow. And you can also have shoulder problems if it is left into varus for a very long time. And very rarely, cubitus varus can also cause cubital tunnel syndrome and cause ulnar paresis. So after maximum remodeling and range of motion is restored, at 1 year you do the osteotomy. You have to correct the varus. The recurvatum and rotation may be ignored. The more complicated you make an osteotomy, the more complications you will get. There is a lot of evidence and lot of papers which have suggested that only varus correction done adequately is good enough. Sometimes you may need to correct the recurvatum. Rotation can be ignored. So this is classic French osteotomy. I'll show you what I do. So this was a case of a supracondylar fracture with cubitus varus. See, I always do an oblique osteotomy. I take a cut from the supracondylar region. My apex is the medial epicondyle. And I do not cut all the way across. I green stick this area. So I take a cut from here to the medial epicondyle and a 1 centimeter wedge. And then I green stick this and see how much correction I have got. If I feel clinically the correction is correct, I will use a lateral column plate because that is very secure. A TBW always tends to slip. So I don't like that. I put a plate. If I feel the correction is less, I cut more bone on the proximal side and then I close the wedge. So it's a closing wedge osteotomy. Now this child, you can see this child had a varus. Somebody did a classical French osteotomy and he developed AVN. You can see this AVN. And after a few months, he got a recurrence and he came back to me like this. Yeah, somebody's mic is open. Can you just shut the mic? There's a lot of background noise. So you can see that this is what happened. There was a AVN of the trochlea and this migrated up and there was a recurrence of varus. So now what I did was I made a very low osteotomy and I put a clip or a staple plate. That means I put a screw into the lateral condyle across the growth plate to stop the lateral side from growing. And that is the deformity correction at maturity.
Sir, how long did you pass the screw, sir, in phases?
How long in the sense length?
Yes, sir, length of the screw.
Yeah, short of the medial side. You don't go across from the medial side. So that is how you treat. If there is AVN, you go a little distal and you cause epiphyseal disease on the lateral side. So that is how I do an osteotomy. An oblique osteotomy, apex on the medial side, medial epicondylar side. Okay.
Oh, so you decide on table, sir, by clinical, like how it sees.
Clinically, you always extend the elbow and see the carrying angle. So you must preoperatively look at the opposite side, what is the carrying angle, and then decide how much you want to correct. You cannot go with a fixed idea that I'm going to do this much. You must reassess it on table.
Which approach you suggest, sir?
Lateral approach. You can go by dead lateral approach or a posterolateral approach. I do it in supine position with a lateral approach going in between the muscles of the flexors and the extensors, right on the pillar. And then just subperiosteally put your spikes, make an oblique cut, put a guide K wire, look at the C-arm and cut parallel to it to the medial epicondyle. Okay, and then remove bone proximal to it about a centimeter. I always use a recon plate which is pre-contoured. I bend it with my hand and then I put a single screw in the distal fragment and leave it loose so that my distal fixation already is there. I put it before I cut the bone. Leave it loose, turn it around, make your cut. Green stick it in extension. The cut has to be made in flexion so that the vessels are away. But when you correct it, you must do it in extension. And then you see the clinical alignment. If you feel it is undercorrected or rectus, cut more bone and then make it straighter. Get about 5 to 7 degree valgus and then put the upper screw. So it acts like a tension bind plate on the lateral column. It's very secure.
So you put the distal screws first, then you cut it, sir.
Yes. So
Thank you,
that
sir.
I don't have to juggle around with a osteotomized distal fragment, which I cannot hold and fix it very cleanly. Okay.
Okay.
Thank you, sir.
Yeah. Any
Hello,
other
sir.
questions?
May I, sir?
Yeah. Go ahead.
Sir,
Whatever you want to ask.
regarding a supracondylar fracture with absent pulse.
Yes.
So in this situation, in every case, it's difficult to do Doppler and CT angio. So should I,
Absolutely.
because most of the time it is spasm.
Correct.
So in after reduction, the pulse will come. Suppose in
Absolutely.
case if pulse is not there, so in same setting we'll open and will what with the protocol means what
No. So how bored are you? It is 10:10. Okay. You have time. Shall I take a talk on pink pulseless hand?
Sure, sir. I have.
Okay. And after that, we'll stop. Then I think it will be too late otherwise.
Okay,
Otherwise, I can just keep on going till 12 o'clock at night. Then
because
everybody will
lateral condyle is also pending.
Yeah, no. Tomorrow we'll do one more session on lateral condyle and trash lesions.
Yes, sir.
That
Okay.
is again 1.5 to 2 hours I'll take for that.
Yes, sure, sir.
So I'll take the pink pulseless hand top because that is very important and it's a good thing you brought it up. Otherwise, it would have remained untalked about. Yeah. So let me just open it for you. Not this one. Pulseless supracondylar. Yeah. Okay. So I will share my screen again. All right. Can you see?
Yes, sir.
Okay. So let me just start. What is the evidence and how do we treat it? Right. So these are the common problems, like you said just now a minute ago. Yeah.
Yes, sir.
These are the dilemmas that a person has. Should I refer to a higher center or should I treat a pink pulseless hand?
Yes, sir.
Yeah. Second, what investigations do you need to do? Do you need to do Doppler, CT, MRI, angiogram? Should I involve a vascular surgeon?
Absolutely. Same question.
Do you think he needs exploration and will the hand survive? Right? So
Right, sir.
I'm going to answer all these doubts so that it's absolutely clear what you need to do. So just look at 3 situations. First is where you have a type 3 supracondylar, widely displaced, pulse is present, hand is pink. No controversy. Okay? Pulse is there, hand is pink, type 3, close reduction, percutaneous spinning. Okay?
Yes. Yes, sir.
Second situation. Type, type 3 supracondylar, absent pulse and pale hand. Okay? which means hand is not perfused.
Hmm.
What you do is close reduction and percutaneous spinning first. First you reduce it. When you
Okay, sir.
reduce it, either the hand becomes pink or it remains pale.
Okay.
If
Okay.
it becomes pink, it means that perfusion has come back. Okay?
Hmm.
And if it remains pale, it means perfusion has not come back.
Okay.
In pale hand, you have to explore. There is no question.
Okay.
Okay? Now the question is, what do we do when there is no pulse but the hand is pink? Either it is at presentation or after reduction of a pale pulseless hand. Right? This is always the dilemma. There is no pulse but the hand is pink and type 3 supracondyle. Now, question is whether you want to observe or explore. There are two important factors which you must examine in addition before you make your decision. The first is understand the difference between pulse and perfusion. Right?
Okay.
Absence of pulse does not mean under perfusion. If the hand perfusion is good, the hand will always survive.
Yes, sir.
And the second thing that you need to look at is what is happening to the nerves. Okay? Okay, these are the two important things that you must examine. How is the perfusion and what is happening to the nerves, which means median nerve especially. So does no pulse mean no perfusion? And look at what literature has to say. Lally electively ligated the brachial artery above the elbow for doing something called as a Scribner shunt for dialysis. And Lipscomb actually resected the whole artery. And what did they find? That loss of brachial artery is completely compatible with an acceptable function in the absence of a neurological injury.
Okay.
Right? What does that tell you? If you have the collateral circulation around the elbow is so good that even if your whole brachial artery is cut, resected, ligated, the hand will not become black and die.
Okay.
Because of excellent collateral circulation. Having compartment syndrome is a different issue. Here we are talking about survivorship of the limb.
Yes, sir.
Provided the hand is perfused and is pink, there is no risk of turning gangrenous. So don't worry about that. Okay?
Okay.
Now, what about the nerves? The pink and the pulseless hand normally conveys the impression to everybody that it is a pure vascular problem, which is not the case. With every vascular injury, 56 nerve lesions of the median nerve happened in 26 children. Okay, this has been proven. If you have a hand which is surviving because it is well perfused, but because the median nerve is damaged or trapped and there is no function, the hand will become disused. Do you understand?
Yes, yes, sir.
So the poor function doesn't happen because of lack of perfusion. It happens because of neurological injury. Okay, so that is the second important thing. So when there is a coexisting median nerve palsy which is deepened or dense, it is strongly predictive of a nerve and vessel entrapment. So a pink pulseless hand with a dense median nerve palsy with an inadequate reduction on the lateral view, which says that there is a gap, there is no bone-to-bone contact, should make you alert to the possibility that their nerve is entrapped in the fracture. In this situation, the hand may still be well perfused. It may be pink, it may be warm. But on the X-ray, if there is a gap at the fracture and there is a deep median nerve palsy, you will still explore for the nerve, not for the vessel.
Okay.
Are you understanding what I'm saying?
Yes, sir. Yes, sir. Yes,
Yeah.
sir.
So the next is, how do we investigate? Once you have these concepts clear, how do you investigate pulse versus perfusion? The pulse can be looked for by a handheld Doppler, and pulse oximetry in addition can be useful. So when you look at a pulse ox, you look at the waveform as well as the amplitude. Only the waveform is not important enough. This shows diminished flow. A high amplitude shows a good flow. And muscle flow is important for predicting compartment syndrome and VIC. And angiography is not really indicated at all because the Doppler will give you adequate information. The Doppler is non-invasive, it is rapid, it is safe, it is cheap, it is available everywhere. Whereas an angiogram is invasive, time consuming, and is more costlier and it's not really required. Okay? But it may show you good collateral circulation.
But
So,
some radiologists told in severe spasm, it's
who
very
told?
difficult.
Who told?
Radiologist.
So, do you want to listen to radiologists?
No, sir. They told in severe spasm for them it's difficult to get. So they advise CT angio.
So that's what I'm saying. They want just to do one more investigation.
Okay, sir.
What I'm trying to tell you as a practicing orthopedic surgeon is that clinical examination takes higher precedence over any investigation.
Yes, sir.
And a non-invasive handheld Doppler gives you adequate information.
Okay.
If your hand is warm, capillary filling is good, you don't have a nerve lesion, and there is no pulse, you should not get scared. Nothing happens.
Okay, sir.
Okay. So I'll just go through the presentation. You'll understand further.
Sure.
Clinical correlation is important. An angiogram or a CT angiogram is not indicated. There is no advantage of showing that or getting panicky about it. How do you evaluate perfusion? This was about pulse. Okay. And I told you what is more important, more than the pulse, perfusion is important.
Yes, sir.
Okay. And that is more or less clinical. What is the color? What is the speed of the capillary refill? How much does the child have pain? When you ask him to move the fingers, if there is deep ischemia, they have severe relentless pain. After your reduction, if the pain goes away, then they don't have ischemic pain. And you have to look at muscle activity. Okay, so capillary refill is very important. You can see here in this video.
Yeah. Yes,
Can
sir.
you see this capillary refill?
Yes, sir.
And
Good.
look at, this is normal. You can see the IV here. Now look at the affected side. This is definitely sluggish.
Yes.
Yeah. See this, it is filling, but it is slightly slow.
Yes.
Whereas you look at the earlier one, I'll play it again for you.
Yeah, I got it.
Yeah. We'll go back there. So this is the affected side. You can see slow filling. It
Yes,
remains
sir.
pale for quite some time.
Yes, sir.
Yeah. And compare it to this. Immediate filling. So this should make you understand that there is poor perfusion. Poor perfusion is not a good thing. This is pre-reduction. After
Okay.
you reduce it, if the perfusion improves, your X-ray on the CM, there is no gap and it's a stable K-wire fixation and there is no nerve injury. You will have to just give a slab and wait and watch. Functional evaluation and muscle activity
Sir,
are
excuse me,
very
sir.
good. Okay?
Sir, we will do close reduction under anesthesia. How will you
Under
check for
anesthesia.
nerve?
Yes.
How will
Yes.
you check for nerve recovery, sir, after close reduction
No,
and
no, no,
pinning?
not nerve recovery. I am telling you, preoperative, there is no nerve injury. There is going to be no nerve recovery.
Okay, sir. So if there is nerve injury pre-op only, so you will go for exploration directly.
Just listen to me, no? Just listen to me. I have not completed it. Yeah. So now what happens is that you look at literature. Okay, Los Angeles team versus Cincinnati team. These guys said pulse is important. And these guys said perfusion is important. And they published. Okay, so these guys thought that even if collateral is good, they may have some long-term dysesthesias. Whereas the Los Angeles team said that even if there is no pulse, they have excellent function and nothing happens. Okay?
Okay.
So how do you manage? One option is doing thrombolysis, like the cardiac surgeons or the angioplasty surgeons do if you have a heart attack with thrombus. Okay,
Yes.
you can put some streptokinase and open it up. Okay, but that facility is not available in most places and it's not really useful. This is an example where you can show that artery has opened up after. You can see the K-wires also here.
Yes, sir.
Thrombokinase was injected and it opened up. But you can see that artery is narrow here. So it does not guarantee against restenosis. So it can be just a temporary solution and it is invasive and not really required. If you look at papers which talk about exploration, most of the papers come from plastic surgeons or vascular surgeons. there are hardly any papers from orthopedic centers who have talked about exploration. So they say that long-term ischemia may cause claudication, cold intolerance, sensory motor problem. So it is better to explore and restore the pulse. Okay. This is their thought process. So they said that surgical exploration for every patient. Okay. In presence of a viable pink hand after close reduction. And they did an artery graph. But if you see Blakey's paper, he showed that as late as 3 months, a hand which was pink and pulseless, the pulse was not important. The muscles had fibrosis because of muscle ischemia and 41 nerve lesions due to swollen muscles or trapped nerves in the callus or caused by K-wire. And that caused the problems. Okay, so they say that decompression of the nerves is important in restoring function. It is not important to deal with the pulse. Okay, and there is a large number of papers. You can see Blount, Paul, Watson Jones, John Chanley, Shonecker, Sanjeev Sabharwal, Malviya, Choi, and last is our own paper from Ganga Hospital, Raj Shekharan's paper, 2011. Okay, what they showed, Sanjeev Sabharwal in fact showed that after doing a vascular repair, there was a very high chance of restenosis. So early revascularization by a vascular surgeon and putting an graft. After 7 days, that graft is also thrombosed. Okay, and the hand is actually surviving on the collaterals. So doing a vascular surgery does not mean anything. Your hand actually survives on the collaterals. It doesn't survive if you have restored pulse. So he recommended observation and not doing vascular repairs. And again, a lot of papers have shown that it is the collateral is so good, it is adequate to maintain a viable extremity. Turning black or creating gangrene unless the artery is transected doesn't need any kind of intervention. Okay, there is enough vascularity. Now, this is the Ganga Hospital study. They had 105 type 3 supracondylers, of which 12 were pink and pulseless. They did an immediate close reduction and pinning. Of those 12, 5 got an immediate return of pulse after reduction. 7 of them still did not have a pulse. The question was whether to explore or observe. So they chose to observe. They saw that the pulse returns in 48 hours in 2 patients. In 5 patients, they still had no pulse, but the hand was well perfused and pink. And then they observed this periodically for over 6 weeks. A few of them got the pulse back after 7 days, but all of them, in spite of pulse being there or not there, none of them developed compartment syndrome, and fracture reduction alone was sufficient treatment in all the cases. Half these patients had an absent pulse but well perfused hand and did well clinically. Okay, but if perfusion is poor, there is stretch pain, there are high chances of compartment syndrome and VIC. So what are the red flags? What are you supposed to do? That was the question. If you remember your earlier teaching, like Dr. Nitin Patil was saying, we were taught to look for the 5 P's. That is poor perfusion, pain, palsy,
Paresthesia.
and progressive ischemia. Okay, or pallor. Right? This is no longer true. In today's era, if you are waiting for the 5 P's to appear, you are too late. You should look for the 3 A's. What are the 3 A's? After your close reduction and pinning and slab, admit the patient. Do not discharge him. And look for whether the patient's anxiety is increasing, whether he is getting more and more agitated, and whether his requirement of analgesic is increasing or decreasing. Right? So monitor the 3 A's. If the pain persists or worsens after reduction, you are looking at ischemic pain. That is an important pointer. And beware of the median nerve dysfunction. So the rational approach for you, which is again published in recent literature, it is reasonable to monitor carefully a pink pulseless hand for 2 days after satisfactory reduction and pinning. If the perfusion of the hand deteriorates or the pain worsens and there are signs of deteriorating neurological picture, exploration of the nerve and artery is mandatory. after 2 days, even if you explore, the results are the same. But 99 out of 100 times, you will not need to do this. So your treatment has to be close reduction and pinning. Look at the adequacy of reduction. You may document your lesion with a Doppler. Watch for the 3 A's. Counsel the parents in advance of the possibility of exploration. Observe for deepening ischemia or neurology over 2 days. If his requirement of analgesic reduces, muscle activity improves, stretch pain is reducing, and child is laughing, feeding well, moving fingers, 3rd day you can discharge. If none of this is happening, you will still explore. Imperfect reduction, deepening ischemia, concomitant median nerve lesions are a red flags for having a very low threshold to explore, and you are exploring to remove the trapment of the nerve rather than restoring vascularity, because the hand is going to be viable on the collaterals and not because the pulse is there. That is for sure. So adapt to your local circumstances. Now, if you have any questions, you can ask. I have tried to make it as clear as possible.
Okay, sir. Thank you.
Is that clear for everybody?
Yes. Yes,
Yeah,
sir.
yeah.
So even in the
Crystal clear.
periphery, don't get scared. Most of the times I get referrals from distances over 200-300 kilometers saying that the hand is pulseless. That is all done in panic. First get a reduction and then see what happens. Most of the times you don't need to rush the patients away. Monitor perfusion, not pulse, and monitor function, and monitor the 3 A's: anxiety, agitation, and analgesic requirement. If the child keeps getting better and better, and when you are waiting for these 2-3 days, if the hand is not pale, it is pink, I can assure you, you will not end up with gangrene. People are scared that the hand will turn black. It doesn't happen. Even if you cut the artery, it doesn't happen. People have electively clamped the artery for creating fistula, and the collaterals are adequate. So it is not a very scary situation. Everybody should understand that perfusion of the upper limb is really good because of collaterals around the elbow.
Sir, may I ask the question?
Yeah, sure.
Yeah. Sir, you said that if hand is pulseless and it's pale, then we do close reduction and pinning, and then observe for the hand if there is
2 days.
perfusion
Yes.
returns or
Yes.
not.
Yes.
So for how much duration we wait for returning of this the pinkish color? What?
No, that pink, after your reduction,
Perfusion,
hand has to
perfusion.
be pink. See, pink means perfused.
Yes, sir.
If
It
it
means if-
remains pale after your reduction, if it is still pale, then you have to explore.
Okay. Means in the pink pulseless pink pale hand, if we reduce the hand and
Yeah.
then we should observe for return of perfusion. Or we should
Perfusion,
fix.
not pulse. You should look for return of perfusion, not pulse.
And immediate fix or without fixing we should observe.
No, always fix. You have to have a stable reduction. If you leave that fracture moving again, there will be problem.
Then after
So
fixing,
your first
for how
job,
much duration?
First job is to reduce and put pins and then observe for 24 to 40 hours. The hand perfusion should come back immediately. The pale hand has to turn pink after reduction. If it remains pale, explore.
For how much time we should see that hand is pale or pink?
You can wait for half an hour at the most on table.
Okay, that's what.
See, sometimes if there is spasm, give some time. If the AC is on, close the AC. Sometimes you give some calcium gluconate. But the hand perfusion should return on table. You don't leave the OT. If it remains pale, if you're not happy, you please explore. And if there was a preoperative median nerve palsy with a pale hand, you have done the reduction. On the lateral view, you're not getting bone-to-bone contact. There is a gap. That means the vessel and nerve are probably trapped in the fracture. Then you should explore.
Yes. And while seeing 3 A's, sir,
this is some stupid type question. How clinically exactly we see that there is increased anxiety and increased agitation? Means
No, so that's what I'm saying. When you see the patient, you see him every 2 hours.
Yes.
Okay, child is always cranky after any procedure and he's been injured. Okay,
Yes.
so you tell the parents to observe. You always ask the parents, don't look at the child, don't even talk to him. Talk to the parents, and while talking to the parents, look how the child is behaving. A child who is comfortable and as long as he doesn't feel threatened is not going to cry or shout or do anything. Okay, don't go there and say ungli hilao, wo nahi hilane wala. Okay.
Yes.
Observe him, keep your eye on him, and talk to the parents. Let him watch TV. If he's watching TV, comfortable. A child who has a vascular lesion with ischemia, which is deepening, will be restless. He'll be jumping around. If you have seen an ischemic hand, he'll be restless. He'll keep on moving. He's agitated. He's not lying still, and he keeps on crying. You have given analgesic. The requirement is keeping on increasing. He's extremely agitated. So that is how you judge. If the child has gone to sleep, he's quiet. Okay, there is one important point I forgot. Never let your anesthetist give a block to these patients. No upper limb surgery in pediatric orthopedic should be done under a block. In periphery, there is a large amount of people who use regional anesthesia for upper limb surgery. It is extremely dangerous because pain is one of the earliest signs of a complication. If you take away pain, you will end up with a severe complication which you will regret later. Okay, they do it because they feel it is cheap, or some people just are on a ego trip that they can show that bachche mein bhi main block de sakta hai. Okay, I have made it a strict rule. It has been published and proven that you don't do blocks in upper limb in children because you have no pointer to anxiety, agitation, or a compartment. Monteggia fracture reconstructions, any forearm or elbow surgery, please don't give any regional anesthesia. It masks the pain, which is extremely dangerous. You want pain to be there. And the pain should progressively reduce over a period of time. If you take it away, third day morning, the hand is all gangrenous. Yeah,
Thank
please
you very
reduce
much
that.
for nice point. Yes, sir. Thank you very much, sir. And sir,
Sir, if there is
just
nerve injury
lecture
in the pre-op period only, we go for exploration directly, sir.
Pardon me, I didn't get the question.
Sir, if there is nerve injury on your clinical examination in the pre-op, you go for nerve exploration directly.
No. So that's what I said. After, when you have, you can have a concomitant median nerve injury with a vascular absent pulse. If your reduction quality is excellent, bone-to-bone contact is good, there is no gap. Okay, then you can observe, because most of the injuries in upper limbs after supracondylar recover on their own. Hardly any nerve injury needs to be operated upon. They'll all come back in 6 weeks to 3 months. Only if there is a interposition, you will never get reduction if the nerve is in the fracture.
So if the perfusion comes back, then the reduction is good. Then we can wait for 6 to 8 weeks.
Yes,
Maybe
yes,
neuropraxia.
yes,
Okay.
yes. It's usually neuropraxia and it comes.
If it is still there and nerve injury was there, we will go for exploration.
If the reduction is not coming and you have a nerve injury and an absent pulse and the perfusion is not satisfactory, explore.
Sir, do you keep them on blood thinner, sir?
No, I don't give anything.
May I, Sandeep?
Okay, any other?
In any specific position of the elbow to improve the perfusion and specific medications to improve the perfusion, like Trental or Dividilon, something like that. I think he's not able to hear.
But I think his laptop is discharged. He'll be back.
Is it the end of the session?
In between, Ashok sir, may I ask a question with you, sir?
Yeah, sure.
Sir, actually, I was disconnected in previous session, so I could not ask that question.
Yeah.
For supracondylar humerus fracture reduction, I can
Mhm.
see column reduction by or rotatory view, lateral column and medial column, and I
Yeah.
can see here humerus line in lateral view. But
Yeah.
do we practically see the Bowman angle in C-arm image and assess, sir? Do we practically see it Bowman angle in C-arm image? Means we check for
No.
column reduction, we check for anterior humerus line in lateral view, but do we practically see Bowman angle? I find it very difficult actually.
Yeah, it is difficult to see that.
Yeah.
What I'll do is I'll share the video that sir has displayed. Just see
Okay.
on that, and you will find that it is not. Once you have the orientation in your mind clear, you can decide on the AP reduction also properly. Once you take the CM image on search technique, it is very easy to even assess the AP reduction. That's what you are looking for, right?
Yes, sir. Especially for Bowman angle. Seeing Bowman.
So you can make out in that CM image. I'll share the video with you.
Thank you.
I'll share the video in the group itself so that you all can have a look at that. Let me see how sir is connected or not. I'll check with him. I think rest of the questions you can ask on the WhatsApp group also, and also at the beginning of the next session you can ask. We'll keep some time for asking.
Ashok,
Okay. Yeah,
yeah,
Sandeep sir is here.
I just lost internet for some reason. I don't know. And my phone died, so my phone is shut down.
Okay. No, we can hear you. But I was telling them they can ask more questions on the WhatsApp group.
Yeah, on the group, I'll answer all of not a problem as I get time and answer them. I see some case or interesting.
No, your audio is completely gone.
Yeah, I can't do much.
No, we'll sort it out tomorrow when we meet. So not
I don't know what is happening.
Yeah.
What
So
time
they can-
tomorrow? Same time?
No, it will be next week, the live session. You can ask questions on the WhatsApp group.
Next
And
Wednesday.
yeah, and the next time when we begin the session, we can have some 5-10 minutes question answer for today's session.
Yeah, no, I think we've covered. Can you hear me?
Yeah, we can hear you. You can
Yeah,
speak
I
slowly.
Yeah, I think we have covered a lot of things, including reduction, types, spins, complications, method of reduction. Anything that is pending, we'll answer them. Next time, we'll do lateral condyle, trash lesions, and take any more questions for around the elbow thing.
Yeah.
Okay.
So we'll complete elbow in 2 sessions.
Yeah.
So you can post your questions now also in WhatsApp group, and next time also you can keep the questions and ask.
Rohit, what do you do about compartment syndrome? So in the 48 hours that you are observing, if the child develops stretch pain, you must do a thorough fasciotomy from elbow to the forearm wrist and do a fasciotomy, leave it open. So if there is a compartment, or sometimes your vascular surgeon may have done a reperfusion surgery. In reperfusion surgery also, if they don't do the vein properly, they can end up with more blood flow and compartment syndrome. So after a reperfusion surgery like a graft, you should electively do a fasciectomy and then close the wound after 2 days rather than risking a complete VIC and a deformity and buffer. But it's mandatory to do a fasciectomy for a vascular repair. If they have done just a thrombectomy, you can afford to observe. But again, there is chance of rethrombus, and whenever you see there is an increase in stretch pain, don't waste a single moment. And whenever you are taking IV supracondylar pulseless hand, give a slap, not a cast. Wait for 24 to 48 hours, and then convert to cast. So don't be in a hurry and never actively flex.
Are there any medications to improve the perfusion, like Trental or Duodilon?
Sir, they are all theoretical. It is not proven that they cause any great improvement. It's anecdotal. What works is, I prefer to give one shot of dexamethasone. I give a steroid to reduce the inflammatory response and muscle edema, because there may be a lot of muscle edema. And in addition to that, any elbow injury, I prefer to use indomethacin for 3 weeks to prevent myositis and stiffness around the elbow. I find that is quite effective.
Okay. Any specific position of the elbow to improve the perfusion in a suspicious hand?
No, not any less, which is very comfortable. Why the pins have to be there? Pins are reduction.
Without elevation? That will decrease again.
The child is lying down, you give a elevation to an IV stand, not very high. On the bed.
Okay.
Sir, how much was sir, the youngest child in which you did pinning for supracondylar humerus? What was the age?
No, age-wise, 18 months. We are seeing very young kids falling off. They all go out play on the sofa or trampoline. They have 18 months in supracondylar. Okay.
Sir, good evening, sir.
Yeah.
Sir, supracondylar with intra-articular extension, is there any fixation method apart from this supracondylar?
So supracondylar with DY elbow or intra-articular extension, you will see in adolescent age group, not very young kids.
In some age groups, in pediatric age groups also, that pattern is
there.
there.
So it's very unusual, and we see it usually 9 to 13 or 14 years, maybe in the older age group. So in that, again, what you can do is you can do a close reduction, get your pillars aligned, do an arthrogram. If on arthrogram the joint line looks good, you can just put a clamp without opening it, put a transfer screw, 4 mm cancels, half threaded. You don't have to go like an adult to bicolumn plating or do any kind of translational hospital. Usually it work unless the fragment is flexed or the child is like an adolescent, it's 14, 15-year-old. We nowadays get very huge adolescents, hefty, obese, and they are playing basketball or something or skating, and then they fall and then you treat like an adult.
In stiffness cases, sir, how can you get out from that?
Pardon me?
Stiffness post-operatively.
Yeah.
After removing the pinning, some of the cases presented with some stiffness till the 3 months down the period, sir.
Yeah.
How can we get out from that?
Yeah, about one story in the sense, I have had a couple of supracondylar fractures who had post-operative post-plaster stiffness treated elsewhere, and they were sent to physiotherapist. And the physiotherapist thought that he's going to senior physiotherapist who did some acute manipulation about a repeat fracture. I have 2 or 3 such patients. I have an X-ray. Next time maybe I'll bring them out and show you. No child with an elbow fracture we send to a physiotherapist? Nobody. After the pins are removed, they have to be asked to change active range of motion, no passive range, and no forceful manipulation at all, ever. All of them will regain function. After about 15 days, 3 weeks, if you feel last 5 degrees is disturbing, maybe it can be tried. But acute post don't do anything. Let them use the hand actively, encourage play therapy, let them throw a ball, let them try to lift some books or a bag with about 1 kg, 2 kg. Slowly, slowly, automatically it will come back. Never try to send to a physiotherapist. Our physiotherapist, we never send any child to a physio for elbow mobilization. So all of them exercises at home and they will show every week. If it 2 to 3, I will ask the
You can't hear anything. Maybe it's better we connect next time. You can't hear anything at all.
no stretching, no passive manipulation, active range of motion, and active assisted exercise.
Okay.
Okay. So shall we call it a night, everybody?
Yeah, I think so.
Yes.
And we'll sort out this audio issue tomorrow.
Yeah, tomorrow when you come to Pune, let's
Yeah.
look at my laptop.
Sir, sir, may I ask one more question, please?
Yeah, please.
Sir, in supracondylar humerus, in reduction in CM view, we can
Yeah.
see entire humerus line very clear, and we can see columns also by rotation. But
Yes.
we can't see Bowman angle. Is it practical? Do you personally see practically Bowman angle in
No.
CM?
See, Bowman's angle, all these angles, you see, all these angles have been described by people in the pre-Siam era, in the X-ray era, and there is a big range to the Bowman's angle.
Yes, sir.
The Bowman's angle has got a big range of about 20-25 degrees. Okay. Okay, and it has to be compared to opposite side. So it is like navigation. It is like drawer palace concept of drawing the Cora as well as the mechanical axis deviation. All this is put on X-ray job planning. On table, do you ever draw anything?
No. That's
You
what I think.
always eyeball and you look at clinical alignment. So
Yes.
morphological alignment is important. After you fix it, I always tell my residents and fellows, when you finish your K-wire fixation, please before it should look in valgus.
Okay.
If it doesn't look in valgus, go revise it. Clinical assessment is extremely important. Don't go by radiology all that drawing angles because they are never accurate in draw. And like in TKR also, you draw all this job on table. Where are you measuring? You're still eyeballing it. Or you're using a cautery wire. So what are you doing? Clinical alignment, no? So Bowman's angle is okay for publishing a paper because you need to show angles after everything has healed. But on table, you don't draw anything or nobody draws it. I can assure you that. What you look at is the pillar on top of the other pillar and there is no combination in gross varus collapse, and when I straighten it looks in balance.
Yeah, this was very practical tip, sir. Thank you very much.
Yeah. Okay. So Ashok, shall we end today's session?
Yes, sir.
Okay. Again, sorry for the audio issue. Sort it out.
Okay. Okay. Good night.
Good night.
Good night.
Good night.
So we'll send you the YouTube link by tonight or tomorrow morning.
Okay, sir. Good night.
Okay. Thank you, guys.
Good night, Karthik.
Good night, Ashok sir.
Good night,
Good night,
everybody.
Roy.
Good night, Radha, sir.